Welcome to Radiology Advances podcast. Today we are doing a deep dive into a really fascinating intersection of deep learning and neurological imaging. How do we get these crucial structural biomarkers for neurodegenerative disease without, exposing patients to risk from contrast agents over and over again?
Okay, so what's the source?
We are unpacking the findings from Drs. Ambaye, Joe, and colleagues from Ulsan National Institute of Science and Technology and Ulsan College of Medicine, Republic of Korea. This was published recently in Radiology Advances.
This paper, called Automated Synthetic Contrast Enhanced MRI, improves choroid plexus segmentation in Parkinsonian syndromes. They focused on the choroid plexus, which is getting a lot of traction as a biomarker in Parkinson's disease, PD, or atypical Parkinsonian disorder, APD.
But you need contrast to see it well.
Their goal was to see if a deep learning model could generate a high-fidelity synthetic contrast-enhanced MRI, they call it SynC MRI, from just a standard non-contrast T1 weighted scan.
So if this works, you get the contrast-enhanced view without ever injecting contrast.
Exactly. No more gadolinium needed for this specific test.
Okay, so let's start at the beginning then. Let's frame the why. Why is the CHP suddenly so important in neurodegeneration, and what makes it so hard to image?
Well, for a long time we just thought of it as a CSF factory.
Right.
But it's so much more. It's the blood-CSF barrier. It manages the whole microenvironment of the central nervous system, and in diseases like PD and APD, changes in its size, its morphology seem to reflect things like altered vascular permeability and neuroinflammation. It makes it a really attractive potential biomarker to distinguish between different disorders or even just track progression.
But the imaging hurdle is still there. You've said a standard T1 weighted scan, which is what we use all the time, just doesn't cut it.
No, it really doesn't. The intrinsic contrast is just too low, especially these tricky anatomical spots like the temporal and frontal horns of the ventricles.
So the gold standard has to be gadolinium.
Has to be. The contrast agent lights up the highly vascularized CHP, and suddenly the boundaries are crisp and clear.
Which brings us right to the clinical bottleneck, that gadolinium dilemma. For a biomarker you might need to check every year, what are the risks we're trying to avoid?
They're pretty substantial, and they're cumulative. First, you have gadolinium deposition. We know it builds up in tissues, including the brain.
And the long-term effects of that are still a bit of a question mark.
Exactly. So we want to minimize exposure. Then there's the possible risk of nephrogenic systemic fibrosis, NSF, especially in patients with kidney problems.
Which is a potential issue because that patient group often overlaps with the elderly population with neurodegenerative disorders.
Beyond that, you have the simple stuff: cost, time, patient discomfort from repeated injections, and possible development of contrast allergy.
Okay, the need is clear, so let's get into the how. How did Dr. Ambaye and the team actually build this?
It was a retrospective study, but they used multi-site cohorts. The main internal cohort had 265 patients, a mixture of people with PD, APD, and essential tremor.
And they validated it externally.
Yes, and this is key. They used an external cohort of 58 patients from a different location, a different time, even a different scanner vendor.
That's important to show generalizability. Now, the architecture, they chose a nested UNet or NUNet in combination with peak signal-to-noise ratio, PSNR-oriented models, and generative adversarial networks, GAN models. Why that specifically?
That's a great question. They're great at making images that look real, but they can sometimes prioritize, let's say, visual plausibility over perfect structural fidelity.
And for diagnostics, fidelity is everything.
Everything. The NUNet architecture is engineered for multi-scale feature aggregation. It means it's really good at combining the big picture context, the overall brain structure, with the tiny fine grain details, like the exact edge of the CHP. For a small complex structure where the boundary is key, NUNet often gives you better, more verifiable structural accuracy. The PSNR orientation also helps ensure fidelity at the level of individual voxels.
And the numbers back that up. How good were the synthetic images?
The fidelity was extremely high. They reported a PSNR of 35.37.
And for our audience, anything over 30 is generally considered excellent, so
It's very good. It means the synthesized image really replicated the voxel intensities, but more importantly, they look at structural integrity. The Structural Similarity Index measure, or SSIM, was 0.970. That's incredibly close to a perfect match of 1. These metrics together confirm the output didn't just look good, it kept the structural information you need for segmentation.
okay, so generating the image is step one, but it's only a means to an end. The real test is, can you use the synthetic image to accurately segment the CHP and get a reliable volume?
That's the whole point, and we know how hard this is. The paper shows that manual segmentation on T1-weighted images only achieved a DICE score of 0.59 when compared to the contrast-enhanced MRI ground truth. And even inter-rater agreement between experts was notably lower on T1-weighted images, a DICE score of 0.69 compared to 0.98 on contrast-enhanced images.
Wow, so even the experts can't agree when the contrast isn't there.
Exactly. So how did the automated model do on the synthetic contrast images?
Let's hear it.
The results were much better. The model achieved a DICE score of 0.803.
A jump from 0.59 on the manually segmented T1s to over 0.8.
It's the difference between a research idea and a potentially usable clinical tool.
The DICE score is about boundary agreement. What about the final number, the volume? How close was the volume from the SYNC MRI to the true volume from the real contrast-enhanced MRI?
This is where it gets really compelling. The agreement was almost identical. The mean absolute volume difference, or MAVD, was just 6.7%.
Only 6.7% off. That's well within the margin of error for a lot of manual measurements.
It is. And the intra-class correlation coefficient, or ICC, was a strong 0.88. Compare that to trying to measure on a standard T1-weighted image, where you'd underestimate the volume by almost 30%. The synthetic contrast just works for this.
So the tool is validated. It's accurate, reliable, non-invasive. What did they find when they applied it? Did it reveal anything new about the CHP and these Parkinsonian syndromes?
It did. This is the clinical payoff. Using this pipeline, they found a clear morphological difference between the patient groups. The CHP volumes were significantly larger in the atypical Parkinsonian disorder group, the APD group, compared to the Parkinson's disease or PD group.
So the enlargement is more pronounced in APD, which is often more severe and faster progressing.
That's right. For instance, in their internal cohort, the APD group had a mean volume of 2.69 milliliters versus 2.43 milliliters for the PD group, and that trend held up perfectly in the external cohort too.
So this gives clinicians a quantifiable metric that could actually help in that tricky differential diagnosis between PD and APD.
Potentially, yes, or at least help stratify patients for clinical trials. It takes CHP morphometry from being this high-risk, expensive thing to something you could get from a routine scan.
Now, we've established the volumetric results are stellar, but the authors did note a little nuance. While the volume agreement was high, the DICE score, the segmentation metric for SYNC MRI, was a little lower than a perfect score against the true contrast-enhanced MRI. Why was that?
Yeah, that's a subtle but important point. They think it's due to a slight smoothing effect from the synthesis process. The deep learning model, while getting the overall volume right, might just slightly blur the absolute sharpest edges compared to a true contrast image.
So you're trading a bit of boundary perfection for avoiding contrast administration. Is that a good trade?
I think so. The key is that the smoothing didn't actually hurt the final volume measurement. That MAVD of 6.7% proves it. The critical finding that APD volumes are larger than PD volumes was preserved.
So we've moved from validating images just on how they look to validating them on whether they give us the right data.
Precisely. The pipeline works and was tested on an external cohort which provides support for its clinical utility.
Okay, so to summarize, SYNC MRI powered by this NUNet gives us a non-invasive, repeatable, and very accurate way to measure CHP volume from a routine non-contrast T1-weighted scan.
And that makes longitudinal monitoring in Parkinsonian syndromes more feasible. It's a fantastic example of a computational solution to a real clinical problem.
That generalizability is what should really excite people. But let's end with that philosophical point we touched on. Given that the pipeline preserved the critical disease-relevant information, the volume difference between APD and PD, even with that slight smoothing,
really raises an important question for you, the listener, and for the field. How close to perfect boundary-level accuracy do we really need if the main clinical goal is a rapid, safe, and reliable volumetric biomarker? If the synthetic image is proven to preserve the crucial volumetric data, maybe chasing a perfect DICE score becomes secondary.
and that's the core challenge as we adopt synthetic imaging. We're coming to a close of today's Radiology Advances podcast. Thanks to Drs. Ambaye and colleagues for their work published in Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Nelson Gill from Massachusetts General Hospital for accuracy. Thanks for joining us.